Okay, just quickly give summary of your patient.
Yes, sir. We have this 80-year-old male patient with hypertensive, diabetic, ischemic heart disease, which is non-compliant to medicine. Presented to us with complaint of chest pain, shortness of breath, and productive cough from 2 to 3 days. We did the ECG of patient, which shows sinus tachycardia plus LVV. TRAPI of the patient was negative, and the echo shows AF of 25%.
I think you have missed examination, which is
Yes,
again important. So rough finding of your examination.
On examination, there was normal heart sound S1 plus S2. Chest was shows bilateral basal cleft.
Okay.
CNS was intact. Patient was well oriented to time plus and person. And
Okay, let's hold on here. Here you have a middle-aged patient presenting to you with a short history of SOB, with examination showing sinus tachycardia and crepes all over the chest. Possibilities. You can hand over this mic to anyone if we want to answer. G, possibilities.
Young patients.
You can give mic to him. G. He's not young, middle aged, I think. What's the age?
Age is around
80.
80, he's old. And
Well,
this is for the first time he is presenting. So what is the possibility here?
well, I'll keep ischemic heart disease on the top of my list.
Okay, ischemic heart disease, but chest pain was that of typical, or SOB was dominant. Which one was the dominant? SOB or chest pain?
SOP is
So here dominant is SOB. But I need further,
Yeah.
you can say, assessment of that SOP in relation to, if I'm thinking possibilities, pulmonary or
Edema.
cardiac. Doesn't mean that if someone is in cardiac
Cardiac.
unit, it's always pulmonary edema. So after excluding, let's see, we have excluded any alternative pulmonary cause. And you are thinking in terms of heart failure. So now, according to the guidelines which we discussed, 2020 guidelines, clinical presentation and further assessment in relation to heart failure. What is the next step?
What is the next step?
Next
of the
step?
clinical?
Like in this patient? SOB, short history, examination suggestive of heart failure, what next?
We'll go for yes. We'll go for
Anti-pro-BNP and echo, if you look onto that guidelines. Anti-pro-BNP we usually don't do, but he described echo. So echo LVEF 25%. So where you place this patient in terms of classification of heart?
HFrEF, basically.
No, there are different classifications. In a
Stage,
way,
basically.
stage-wise, A, B, C, D.
Yes.
You have classification according to the ejection fraction. Then you have classification according to trajectory as well. So
C.
it's stage C in terms of, in stage C you have disease trajectory.
Yes.
So where you fit in this patient, stage C, and what kind of heart failure? No. Trajectory means clinical status in a way, new onset heart failure, worsening heart failure, progressive heart failure. It's a new onset
heart failure.
because
The
he
first
presented for the first time.
Yes.
So new onset heart failure in trajectory. Then after you have diagnosis, echo is there, EF 25%, ECG, left bundle branch block. Okay? Now you have to give me etiology as well. उसमें आप जाए ना खाने पे फिर आएगा etiology का खाना. Etiology and aggravators. So with this history, what do you think about etiology and aggravators?
Patient have history of ischemic heart disease. Patient have history of ischemic heart disease, and on the top was etiology is due to ischemia.
He had a background of ischemic heart
Yes,
disease.
sir.
How do you know that?
He gave the history of ischemic heart disease.
This, you have to give features. Any PCI, cabbage, admission for MI. Just saying, someone is saying मुझे दिल का मर्ज है या डालियों का मर्ज है is not enough. What is the strong evidence to suggest that he had a background of ischemic heart disease?
Because patient is taking the medication for a long time. So
We usually start any person who's having some changes, and
also
he is
the
already having
ECG shows
LBB.
LBBs.
He may had myocarditis, CMP, and any muscle disease. Due to that, he developed that LBB, and he is put on. For that, you have to ask specific questions. So right now, we don't have any clear evidence about ischemic heart disease. What are the other possible? 80 years.
Hypertension.
Yeah, hypertensive heart disease. What else? Let's take this patient aside. So, what are the common etiologies for HFrEF?
This patient, as patient is old age, aortic stenosis could be one possibility.
Okay,
Aortic stenosis could
but
be one
here we have
possibility.
echo. But
Yeah.
when we are considering causes
Yeah.
separately,
Yeah.
then you can think of valvular heart disease as a reason for heart failure. What else? Hypertensive,
Hypertensive, ischemic, and
muscle diseases,
yes.
maybe sometime drugs, malignancies,
Malignancy.
therapeutic agents, recent
Or-
viral infections
Yes,
leading
infection.
to immunological myocarditis. In young females, maybe peripartum.
Peripartum cardiomyopathy.
So that means whenever you are diagnosing someone with heart failure, it's not just the diagnosis of heart failure. It's important to search for etiology right from the beginning with history. So objective of history taking in a patient with short SOB or clinical features suggestive of heart failure, you are thinking that this is a possible heart failure, then you have to take other evidence into account to classify and for etiology. Then you have to give features which have aggravated this heart failure. So in this patient,
There is a respiratory tract infection, as he has mentioned. So that could be
prime
the cause.
is infection, but what are the other aggravators?
Non-compliance to the medication is the most common after infection.
What
And
else?
Ischemia and anemia, electrolyte abnormalities, and arrhythmias, uncontrolled hypertension.
Anything else?
Um, anyway,
Anemia we discussed.
non-compliance and
Hyper and hypo both.
hypothyroidism.
What else? Infections we already have discussed. Increased salt and water intake.
Yes.
That is non-compliance. Yeah, non-compliance to drug
Yes.
or drugs which are retaining
Like
NSAID,
NSAIDs.
steroids, and all other. So now, after searching all these things, are we there somewhere to say that this patient has this is the here you have lower respiratory tract infection as an aggravator, maybe ischemic heart disease as cause. Let's assume this is all. How you manage this patient? Acute
Yeah.
and long term. For that, you have to give some parameters of your hemodynamics at the time of
Yeah.
presentation. What were the hemodynamics? Heart rate, blood pressure.
At the time of presentation,
Yeah.
blood pressure of the patient was 112 by 74 millimeter mercury.
Such.
Pulse of the patient was 82 beat per minute. Saturation 94%, and temperature patient was febrile.
So he was maintaining blood pressure, no state of shock. So how you manage?
So in this case, there is no need for invasive hemodynamic monitoring.
Okay.
So I will check the saturation of the patient, and if it's short of breath, I'm gonna go with oxygen supplementation with a face mask. After that, I would go for diuretics.
IV diet.
IV diuretics to relieve congestion of the patient. And after initially the patient has been stabilized.
Let's see after 1, 2, 3 hours with IV diuretics, he's improving.
Yeah.
He's not euvolemic completely, but improving. Respiratory rate is improving, and saturations and clinical status is improving. So what else you'll give?
If I would check the status of the patient and to see for beta blockers. I want to start if the patient is improving and
Okay.
stable. It's not.
But prior to beta blocker, would you like to start?
If the patient is not already taking ACE or ARBs, I can start early.
Early class 4.
Underlying cause.
Roughly maybe ischemic, but this time he's having no ongoing ischemia. This time it's lower. But guidelines still are suggesting in function class 2 to 3
Yeah.
ARNI, not in 4. He's presently having resting avert heart failure. So I'll be waiting for ARNI till at this time I may start ARB because then switching to ARNI will be easier.
Easier.
In ACE, if I've started, then switching will be difficult. You have to wait for 36 hours and then restart ARNI. But ARNI doesn't mean you can't start in hospital. But considering the evidence, there are few evidence suggesting you can give in acute avert heart failure as well. But guidelines are still saying, हमने वो उस दिन भी discuss किया था ना, NYHA 2 to 3, not in 4, but he is in 4. So ACE. And looking after what things? Potassium, creatinine if I am giving ACE. कि baseline potassium मेरे पास आ चुका हो, baseline creatinine आ चुका हो. A number of time people don't give ACE because of raised creatinine. This is a wrong strategy. If his potassiums are okay, is maintaining a good pressure and urine output is there, then irrespective of creatinine level, unless and until the creatinine clearance is less than 20, then it's something different and stage renal disease. If it's around 30, 20 to 30 borderline, above 30 है और patient का pressure ठीक है, potassium बढ़े हुए नहीं है, you can start ACE. So ACE can be started once your patient is getting euvolemic, unless and until reasons for starting rate limiting agent like arrhythmia or ongoing ischemia. These are the two different things. There you may need beta blocker early. Once your patient is out of failure, slightly even hypervolemic, you can give beta blocker. But if he's not having any arrhythmia, no ischemia, then I'll wait at least 12 to 24 hours once my patient is completely euvolemic, is maintaining pressure on my ARB as well, then I'll be starting beta blocker. So ACE or ARB, beta blocker, and once stabilization at the time of discharge, you can switch to ARNI as well. It's your own judgment or whatever you think, or still you can continue with ACE or ARB. We commonly give ACE like enalapril here in our patients. Then beta blocker, what else?
Spiramide.
Aldosterone antagonist. But again, when you're giving aldosterone antagonist with RAS blocker, potassium. Very important to really maintain potassium levels. What else? Ideally SGLT2 inhibitors as well. But since his baseline pressures are 100, remember that 100, 110. Number of time I have seen, because we keep these kind of patient admitted for 24 to 48 hours maximally. And at the time of discharge, you have written everything. And 1 week after he's coming with 80, 70 systolic pressure, even SGLT2 slightly affect blood pressure because it's take the volume out. And so you have to be very careful in terms of that. You are expecting the potential trends of pressure. Because here you have, if you have a patient who's not taking any medication, and you have started ACE, you have started beta blocker, then you expect their effect to be gained after few weeks, their maximum effects. So you're bound to have some drop in pressure afterward. So that's why you have to be very careful in seeing the trends of pressure in hospital. Like you have started these drugs and next day your patient's pressures are 100 and even 90. Then I would even decrease the dosages of the drugs which I have started, because once I want to see in routine practice how they behave, how they affect on pressure, and then see on follow-up. So all these 4 medications, which are the 4 pillars, should be started gradually, progressively, unless and until right from the beginning your patient's pressures are 160, 170. Let's discuss what are the things you have to look for when you want to up titrate your heart failure medication according to the guidelines in patient's base status. Blood pressure
heart
key.
rate.
That is in one of the presentation I have seen, a person has made a bank. This is the bank and this is the thing you having in your bank before investing thing. Pressure, heart rate,
Electrolytes.
renal function.
Yeah.
What's the status of renal function, potassium, and comorbidities are, that's we discuss arrhythmias, ischemias, because sometimes if you have a patient whose baseline pressure is 90 to 100 and you can give just one medication which can affect pressure, so how will you decide about that medication?
What other symptoms?
What comorbid? Let's see, this patient is having atrial fibrillation.
Yeah.
Then your choice would be rate limiting first. Rest of the drugs afterward. Similarly, your patient who is having ongoing angina, then even sometime beta blocker and then nitrate rather than ACE or ARB, so that your patient should be gone. You have nothing left in your bank of pressure, and now you can't use your nitrate for taking care of ischemia. So that's very important to look for other comorbidities in a patient. Now, these are the conventional drugs which we give to our patients. 4 pillar we already have discussed. Let's come to the next stage.
Underlying cause, I'm going to treat underlying cause,
Yeah.
the precipitant.
Yeah. In this patient, it was infection. So ideally, we should be treating him according to whatever we found conventional, like respiratory tract infection. So what are the things you will look for at the time of discharge after these 4 medications? Diuretic according to the patient volume status. But rest of the 4 according to the comorbidities and tolerance of your patient. Is he tolerating them or not? Let's say you've started all 4 on diuretic and now he's ready to discharge. What else?
I would advise him for salt and fluid.
Okay, what else?
Concomitant. Don't choose drugs that cause salt restriction.
Okay, what else?
And
Being compliant to medication.
Compliance with
So basically,
vaccination.
Yes.
Respiratory tract infection हुआ था इसको as an aggravator. So what vaccination? Pneumococcal and H influenza. These 2 vaccinations should be advised. How you give pneumococcal vaccination?
5 years and
Once in a-
influenza
Every year, and according to the seasonal variation of different regions, we advise that. In our setup, usually it's August to September kind of time when we inject H influenza, which is yearly. And every year you have a new strains, so you have a new vaccines, whether it's available in market or not. Sometimes we don't have, so at least pneumococcal vaccine should be. Let's see this patient in spite of your optimum treatment. After 1 week coming with NYHA 3-4. Not admitted, but still having ongoing symptom. What next? Anyone? Why?
First of all, I would see if I am giving the targeted doses,
yes, we can
and if we
maximize.
can tolerate, then we are gonna go.
Again, reassess, are you missing something in terms of his compliance,
Yeah.
your treatment, pressures, heart rate. If you have liberty to increment your dose, then you have to. Okay, CRT or even ICD, these all are at least 3 months of your maximum optimized treatment, and then see effect of those treatment on ejection fraction as well. Here he has 25%, less than 35 you can think of ICD as well, since he is having left bundle branch block as well.
CRTD.
So what are the criteria for CRT in this patient?
First of all, the patient should be on the.
So let's see, his, even after 3 months,
He
he's having ongoing symptoms. So
QRS complex should be greater than 150.
150 is class 1.
Yeah.
With symptoms greater than 150, the width of your QRS with LBB is class 1.
Sinus rhythm.
Yeah. And if it's asymptomatic or NYHA 1, 2, but still greater than 150 lbb, EF less than 35%, it's 2A.
2A.
It's not class 1. So these are the other things you can offer. So I think from now onward we have very frequent patients of heart failure. और इसका हम फिर क्या करते हैं, पेनल्टी भी इस पे लगानी शुरू करते हैं. अब आप मुझे इस तरह नहीं प्रेजेंट करेंगे कि दिस इज पेशेंट ऑफ पल्मोनरी एडेमा. ये जो कुछ भी हमने आज डिस्कस किया है दैट शुड बी अप्लाइड टू योर क्लिनिकल प्रेजेंटेशन. दिस इज अ पेशेंट हु केम विद पल्मोनरी एडेमा सेकेंडरी टू. अब फर्स्ट क्लासिफिकेशन ये चाहिए HFrEF, HFpEF या मार्जिनली रिड्यूस्ड PA. This pulmonary edema is secondary to this HFpEF. Undiagnosed है तो you tell me we have done the workup and waiting for the workup. But usually we have diagnosed patients here. ये मुझे चाहिए होगा. उसके बाद फिर etiology चाहिए. आपने देखा ना, ये शुरू की चीज़ें हैं. Aggravator चाहिए. And your management strategy for this patient. Acutely तो ज़ाहिर सी बात है डायरेटिक है. Long term as well. Which drug first, which drug second, other comorbidities status, creatinine, potassium, ये एक गो में आप खुद ही बताएंगे. उससे आइडिया हो जाएगा कि आपने पेशेंट को उसी तरह उस नज़रिए पे देखा जो एक हार्ट फेलियर को आपने कॉम्प्रिहेंसिवली देखना है. और इसमें अभी आप अपनी गाइडलाइंस को और अच्छी तरह फिर अब जाके आज देखें उसको किस तरह से आप प्रैक्टिकली अप्लाई करेंगे.